So, welcome again. We are going to begin. And greetings from Spain, by the way. I'm working from Spain this week. It's getting dark already here. Right now, I hope you all are doing well. Welcome to our seventh, I believe, installment of our virtual roundtable series of successful public health approaches, where we feature every 2 months another state, the work of another state, and what they have done to support dementia caregivers across their jurisdiction. And this month, we are hearing from the state of Washington. Maya, would you like to say hi?
Yes, hello, my name is Maya Kofsky. I support the Center for Healthy Aging Innovation, along with the Bold Public Health Center of Excellence on Dementia Caregiving, and looking forward to helping host this event today. Thank you, Elma.
You are welcome. Before we begin, I'm working remotely, but I am able to do my job through the University of Minnesota, and through it, we want to always begin all of our events by acknowledging that the U of M, the University of Minnesota in the Twin Cities, is located on traditional, ancestral, and contemporary lands of Indigenous people. We are grateful, we acknowledge with gratitude the land itself and its people, and we take to heart and commit through action to honor their traditional cultural Dakota values: courage, wisdom, generosity, and respect. Many of you are already familiar with our center, but it just as a brief overview, our center really is, our mission is to support public health departments across our country in implementing and growing their existing and developing future dementia caregiving initiatives. That is, programs really focused on supporting family dementia caregivers of people living with dementia. And we do that in three main ways. We strive to improve access to evidence-based and evidence-informed programs. We act as a convener, facilitating connections and collaborations among public health and a wide range of collaborators, community-based organizations, and other agencies, and the service provider network that they work with. And finally, we provide expert technical assistance thanks to a wide range of partners who are members of our center, from our national leaders and really organizations that are with expertise and knowledge in dissemination and development of tools and programs to support public family dementia caregivers. We are part of a larger national collaborative, the Healthy Brain Initiative Collaborative, a multi-component approach to really integrate dementia and cognitive health and caregiving into public health practice. And I encourage you all, I invite you to visit our website. You can learn about who all are members of our collaborative and reach out to us. Just a heads up, we do have another webinar coming up, which will be about partnerships that public health creates. In this case, we will be talking about partnerships with WEPs, geriatric workforce enhancement programs in universities across the countries. So that's on December 7th. If you can, please join us. It will be a great conversation, and really, depending on the interest and what comes out of that, we hope to maybe offer a follow-up to this initial webinar. So, as I said at the beginning, this is a bi-monthly roundtable series, and it's really geared towards public health. Of course, many of you in the audience are not from public health departments, but really are, again, representing the broad range of partners, and as also people living with cognitive impairment, people living with dementia, and family caregivers, members of our community. In these bi-monthly series, we highlight always the story of one state, the work of one state, and give opportunity to everybody to ask questions and really network and share experiences and ideas. Our ultimate goal with this series is to create a peer community of peers, a community of practice, where you can share with one another and really inform your own work in your states and jurisdictions. These are set up as meetings just to allow us all to be together in this virtual space. And because of that, everybody has the ability to speak up. So just to begin, please mute yourselves and please turn your video on while the presenters are speaking, just to give us all a feeling that we are in a physical space together in a way. And please enter your name and your organization in your Zoom name, just so we know who all is in the room. Any questions that might come up as you hear our presenter speak, please put them in the Q&A in Zoom. We have saved time at the end of the presentation to answer all of those questions. And during that time, if we have, again, if we have enough time, we might be able to allow you to unmute yourself. So at that point, please raise your hand during the Q&A time if you would like to speak. That was about the Q&A. Now use the chat feature to share comments, resources, links. That's our interactive space here together. And use your reaction buttons. The recording, the slides, and all the resources shared today will be emailed to all of you after the event. And just very briefly at the end, we always appreciate your feedback. Thank you very much, because it's very important to us as we improve the programming and the quality of our offerings. So when you leave today's Zoom, you will automatically be invited to complete a brief survey. And tell us about your experience today. I think we would like to get an idea of who all is in the room. And I believe we have a poll set up. For that. And I'm going to try to launch. And again, I apologize if it should now be showing on your screen. Please take a second to tell us who you are representing. It's always helpful for our speakers to know who all is in the room they're speaking to. Thank you. The answers are coming through. Over about a third are community organizations and bold public health agencies. We have such great turnout here on these events, and we are very happy, really, that our public health peers find them helpful and useful and worth the time. I am going to end the poll right now, see if I can share on my screen. I hope you're seeing the results. Right now, as you can see, community organizations are about 33%, bold public health agencies, 20%, and not bold, other public health agencies and departments are 12%. We also have some clinical professionals and others. Thank you for being here today. All right. So without further ado, I'm going to hand it off to our amazing team today, Lynn Cordy and Marcy Gates from Washington State, who will share with us about their state level work on dementia and specifically dementia caregiving. Lynn, would you like to take us up?
Sure. Hi, everyone. It's great to see you. Thanks both Elma and Maya for helping us get prepared and everyone for taking time to be with us today. You do see the essential public health services wheel up on the screen, and these are some areas that I'm hoping to cover today, improving, and innovating through evaluation, assessing and monitoring population health, looking at how we communicate to inform and educate, and strengthening partnerships and using data and evaluation. So if we could go to the next slide, I just wanted to share with you all that my background is in public health, but for a variety of reasons, I've always ended up being tugged towards the aging side. And most of my professional work and my career here at in Washington State has been with Aging and Long-Term Support Administration. So I just wanted to, if we could even go to the next slide, and I just want to share with you a little bit about what we are going to be covering today in this presentation. In the first part of the discussion, I'm going to be providing a little bit of Washington State history around family caregiver supports and their important role in our long-term care system, and also how we have integrated dementia capability within our programs. I'd like to highlight some key approaches to improving and expanding family caregiver support programs in our state, including the use of data, as I just mentioned, caregiver assessment and monitoring, evaluation, and how we've used data and evaluative approaches for policy development as well. And then I'll end my section sharing a little bit about family caregiver friendly policies in Washington State. So let's move to the next slide. And to understand how we here in Washington reach and serve family caregivers, it's important to share a little bit about our history around Washington's long-term care system in general, and explain how supporting family caregivers, including those who care for someone living with dementia, has been an integral part of that system over time. So Washington State has been working to rebalance its long-term care system towards community-based care for decades. And for those not familiar with the term rebalancing, it means spending equitable or more of Medicaid long-term care funds on services and supports that are delivered in the home and community-based settings, as opposed to institutional care. So in the early years of states' long-term care systems, nursing homes were often the only option for older adults who needed help. But nursing homes using medical models of care are not always the best option. And over time, states began to develop home and community-based options to meet the needs of older adults and adults with disabilities. So this work has all been premised on the fact that most people, when surveyed, want to stay in their own homes, or at least in their own communities as they age. And that staying at home or in community-based settings is typically less costly as compared to, say, a nursing home or other institution. And it's less costly to both individuals and to the state. So in order to rebalance the long-term care system, as our older adult population continues to grow, states really need to be continually improving and growing their home and community-based service systems. So these efforts have been underway in Washington since the 1980s. In fact, our first community options program waiver was established in around 1983, and this offered in-home supports under Medicaid in lieu of nursing home placement. And since that time, the evolution of the home and community-based service system has included more and more improvements. So like our Medicaid rebalancing, which started decades ago and evolved over time, so has our support for unpaid family caregivers. So let's move to the next slide. So the Washington State Legislature really recognized early on the importance and value of family caregivers and the role that they play in providing long-term care. So many of you might know that unpaid family caregivers actually provide around 80% of the long-term care in this country. Families are very pivotal in long-term care. So our legislature invested in a state-funded respite care program for unpaid family caregivers in 1989. And then in the year 2000, based on lessons learned in that first decade of the respite program, the state legislature then expanded the respite care program into a more diversified family caregiver support program so that we could offer a broader array of services to unpaid family caregivers. So these were services that we'd seen a need for, such as information about caregiving skills, strategies, some consultation, maybe equipment for the home. But in the next year, in 2001, the National Family Caregiver Support Program was launched with Federal Older Americans Act funding for all states. So that brought a little more funding into Washington State to support caregivers. And then, as you can see on the screen, we have had a number of state-funded expansions for family caregiver support over time. And these are highlighted in the blue font. So you can see in 2007, 2012, and 2017, in each of those periods, we had expansions, expanded state funding, which were really fueled by and supported by the use of data, the investment in a standardized standardized caregiver assessment tool, and some state-based evaluation projects. So Washington State's program for respite care and then family caregiver supports have always been inclusive of unpaid family caregivers of those caring for anyone 18 and over. So it could be a very broad variety of conditions for these family caregivers that they're working with. And even with that broad range of caregivers that we could serve, we know that over time, we have always served a large percentage of family caregivers that are caring for persons living with memory loss or dementia. In fact, we know from our statistics it's between 70 to 80% of families in our programs are caring for a person with memory loss or dementia. So as such, we've been making concerted efforts over time and in a variety of ways to make sure that the family caregiver programs and services are able to effectively serve families of those living with dementia. Okay, we can go to the next slide. Thanks, Selma. So I want to share a little bit about our original family caregiver support program. Again, that one started in around 2000, because this program has actually influenced the way that we have moved forward with supports over time. So our family caregiver support programs are operated through our area agencies on aging. And I'm sure most of you are familiar with area agencies. We call them AAAs. And we have 13 of those in our state to serve our 39 counties. So families typically could enter through maybe the Information and Assistance Program. Some of you call them ADRCs, Aging and Disability Resource Centers, or they could enter directly through our Family Caregiver Support Program at that area agency on aging. So the supports and services that we can provide would be things like specialized caregiver information and guidance, caregiver support groups, caregiver counseling, training on caregiving topics which could include dementia or another condition that they're working with. It would definitely include respite care, and we provide respite care in a variety of settings. And it would also include supplemental services, which might be supplies like incontinence supplies, equipment for the home, PERS, emergency response systems, things like that. And of course, it would also include referrals to additional specialized or wellness supports. So one thing you want to note in this green graphic that's up on the right is that Washington has state general funds for family caregiver support that significantly outweigh what comes in for the national program. In fact, we have well over double, nearly triple the amount of state funds as we have in terms of federal funds for family caregiver support. And what's important to note about that is that we didn't get to this level of funding overnight. It's really taken decades to get to that level of funding. And we have worked really consciously and proactively to increase funding to be able to help our unpaid family caregivers. And we use certain strategies to get there to increase those state funds. And along with, we also wanted to have specific strategies to improve our ability to serve dementia caregivers over time. So that's what I want to focus on for the next few slides. So we can move to the next slide. I know this is a very busy slide, but the point I want to share in this is that Washington, throughout most of its development, has made the decision to embed or integrate dementia capability and dementia-specific supports and services within its larger programs of family caregiver support, instead of creating any kind of standalone program for dementia caregivers. In order to do this, we really took advantage of multiple opportunities where we could build dementia-specific supports, innovations, and dementia capability into our programs. So what you see on this slide here is that you'll notice we have both grant funding opportunities that we used over time, and that's on the top part of the slide above the little dashed timeline. And then on the bottom part of the slide are data or evaluation opportunities that we were engaging with over time. And I'm going to be talking about these. So I do want to highlight that between 1993 and 2016, we participated in 7 different federal Alzheimer grants to develop dementia-specific services and dementia capability. And in all of these grants, we worked with partner area agencies on aging. We worked with the Alzheimer's Association. We worked with varied community organizations to provide services. And we typically worked with the University of Washington to provide that evaluative component in those grants. So from these different opportunities, we were able to develop and demonstrate dementia consultation services, family caregiver counseling, dementia day program, and learned lessons around dementia, around nursing home diversion, and about creating dementia capability. So then you see on the upper part, in 2016 to 2023, to the present day, we had our first Alzheimer plan passed or published in 2016. So we've now gained this sort of additional partners and this new strength and advocacy that open up new opportunities for state funding initiatives that can help dementia caregivers. So on the bottom half of the slide, as I mentioned, these are some different things that we were using in terms of data and evaluation findings that we could use to both improve our programs and expand our services. So I do want to talk a little bit more about those in the next couple slides. So we can move on to the next one, Elma. So I want to talk a little bit, you guys have probably heard of the Behavioral Risk Factor Surveillance Survey called BRFIS. And back in 2007, we had a contact over at the Department of Health. Being Aging and Long-Term Support Administration, we have always had an interest in older adults, and we've tried to work with partners, and we have partnered with DOH in a variety of ways over the years. And one of these ways was, a contact we had with one of the epidemiologists who was very interested in caregiving. And she was actually interested in caregiving, I think, for a personal reason. But she was really interested when we had approached them about including some caregiver questions. And I do want to acknowledge the caregiver module back in 2007. This was actually a predecessor to the current caregiver module that's in BRFIS. So it isn't the same one that's in there. But she was really interested in looking at caregiver traits and needs and impacts across different items in that caregiver module, along with how it connected to some of the bigger pieces of the BRFIS survey data. So one of the important findings when we did that was that we found that dementia caregivers were particularly vulnerable. So first, we found that caregivers of people with that were caring for people with memory loss or dementia were more likely to provide high-intensity care. High-intensity care would be defined as spending more than 20 hours a week for a year or longer. And what we found is that as memory loss or dementia progresses, we found that the caregiver intensity increases, and found that caring for persons with dementia increases the odds of providing high-intensity care by 75%. So next, we found that caregivers who provide high-intensity care have significantly increased odds of serious mental health conditions, such as depression and anxiety, and that they were more likely to be in poorer health. So we were able to use this data and knowledge to focus our next few Alzheimer's grants that I mentioned on the other screen, to focus on developing and demonstrating services to better reach and serve dementia caregivers, and specifically with things like dementia consultation and family caregiver counseling. So it really was informing the sort of design and practice of our programs. So if we move to the next slide, this 2007 data also contributed to the desire to increase funding for the wider family caregiver support program. So in 2007, as I mentioned, when we were talking about expanding our programs, we requested additional state funds for the family caregiver support program. And the state legislature allotted that funding, and they added in this mandate that we develop an evidence-based caregiver assessment, because they wanted to be able to know that we were truly making a difference in the lives of family caregivers. So our team sought out evidence-based caregiver assessment tools, and in the end decided to adopt a caregiver assessment that was developed by Dr. Rhonda Montgomery, which some of you may be familiar with because she was at the University of Minnesota, and Dr. Karl Kozlowski. And they called this program TCARE, or Tailored Caregiver Assessment and Referral is the full name. So their theory and goal was to build a model that would provide the right service at the right time for family caregivers. So also worked with Dr. Montgomery over the next couple of years to develop this model into sort of an algorithm-driven format so that it would be easier to use for our family caregiver support program people. And it was launched in 2009. So TCARE uses this evidence-based cyclical process that you see up here on the slide, where the caregiver the caregiver specialist does like an assessment, a full assessment, to understand how the caregivers are doing and how they're feeling about their role as a caregiver. And in that, they identify any depression or types and levels of burden that the caregiver is feeling. And after that assessment, the system helps to identify appropriate goals and strategies and recommend specific services for supporting caregivers at that particular time. So from there, the caregiver chooses, and the caregiver specialist creates care plans that the caregivers really want to embrace and follow. So then after 6 months, they put the services in place, and then after 6 months' time, the specialist goes back to see how they're doing, and that cycle continues. So this use of T-Care offered a consistent consultative model across the state, allowing caregivers to make informed choices about what would really help them. And it allowed us going forward to both identify caregivers at the highest level of stress and burden, and at the same time, provide some accurate data that would help us in some of our decision making. So let's move on to the next slide. And in 2013, so we put this assessment into place and had used it, and then came along this other opportunity where we could demonstrate the value of family caregiver support programs. And Washington was invited to participate in a study with several other states that were trying out T-Care. And we wanted to be able to understand in this study the difference in outcomes by using T-Care, sort of on a broader scale. So on the screen, you'll see what I was mentioning is that T-Care asks the caregiver about their particular stresses and burdens and their depression and their comfort with caregiving. But it also asks them about their intention to place. So that is, how are they currently feeling when asked this question about the need to place the person that they're caring for or the care receiver in an out-of-home setting? How are they feeling about, like, how much longer can I not do this? So their intention to place. So this, what we learned in this study, as you'll see, we had 84% of the caregivers in that study showed improved outcomes in the 6-month period following that first use of the T-Care approach. And that there was also a statistically significant decrease in the intention to place, meaning people were feeling better about being able to maintain their role. So this confirmed an idea that we had, that by helping family caregivers stay healthier and feel better about their caregiving role, we might be able to translate that into some fiscal savings for the Medicaid long-term care program. Meaning that by helping the informal caregivers, we could keep their care receivers at home longer instead of them going into a higher cost service like a nursing home. So if we could do that, we might be able to provide an incentive for our legislature to expand our family caregiver support program services even further, because it would save state money in the long run. So we began thinking about how to do this, and we had been learning from both T-Care data and from several of the Alzheimer grants that I had mentioned that we could impact caregiver outcomes positively. And we knew in particular from our Alzheimer grants that more intensive supports, or like caregiver consultation or day services, were effective for these caregivers. But we had also noticed challenges through many of these Alzheimer grants and other caregiver projects, because what we were finding, and you guys might find this as well if you're working on the aging side, we tend to get caregivers into our system really late in their caregiver journeys. We tend to get them when they're already overwhelmed, they're so stressed and burdened, and trying new things is just really difficult. So we had suspected that we could be even more effective if we could get to families in the earlier stages of caregivers. So these kind of lessons they sort of informed our next expansion request. Okay, if we move on to the next slide, Elma, what you'll see is in 2013, we had proposed this expansion and moved forward where we would look not just at the caregiver outcomes, but this time also at the potential savings for the care receiver, because we really wanted to test if that was true, if we could help the family caregiver earlier in their journey, potentially with more services, could we impact that care receiver's use of Medicaid long-term care? So before this, many of our AAAs, because they had resource limitations for how much they could provide each specific caregiver, they had established some eligibility criteria which would prioritize the higher cost services like respite care to the caregivers who were most stressed and burdened, which makes sense that we would want to prioritize it that way. But we knew we also wanted to be able to help people earlier in their journey. So in this expansion, we were able to allot more resources that they were able to use and lower the eligibility bar for family caregivers to get those higher cost services like respite care. So for the evaluation, we have this very innovative research and data analysis unit in our department. And they looked at if and when care receivers who were connected to the services, to the family caregivers we were working with, would show up on the Medicaid long-term care side. Then we would be able to compare the costs of these new expansion dyads with the family caregiver or care receiver dyads from a pre-expansion cohort. So we could make a comparison to see if we were making a difference. So what we learned through this evaluation is what you see up on the slide. So the purple line, the top line, shows the experience in terms of time to entry into Medicaid services of the pre-expansion cohort of dyads. Like if we continue doing things the way we were doing it, you'll see the percent using Medicaid long-term care goes up, and then over time is on the other axis. So the green line below it is the experience of our expansion dyads. And those are the people with this new family caregiver support program services who could access services earlier in their journey before they were at their higher levels of stress or burden. So you can see the difference in these lines. The result was that not only was the caregiver's well-being improved, but there was a statistically significant delay in the use and entry into Medicaid-funded long-term care and support services for that care receiver. So the expansion care recipients were 20% less likely to enroll in Medicaid long-term care in the year following their TCARE assessment. So one other thing that we learned, and this is starting to get a little technical, and if you ask me questions about this, I'll have a hard time answering it because this was not my area of expertise, but we also learned that by using 100% state funding, which we were for this family caregiver support program, the horizon for a return on investment was there, but that horizon was longer than a typical budget cycle of 2 years. So what we knew, and we had this sort of goal or a next step, was to try to bring federal Medicaid dollars into the equation through a demonstration waiver. So if we were to use something like the CMS 1115 waiver, for example, Washington State could potentially bring in 100% federal dollars to help us serve more family caregivers who would be eligible for that program. So that's what we did. We started working on that waiver. And so if we move to the next slide, we worked on that for a couple of years, and by 2016, the waiver had gone through we had developed it, gone through the approval process, and it was launched in 2017. So in this 1115 demonstration waiver, it was really modeled after that first successful family caregiver support program, and it offers services and supports similar to what's offered in that program that are really tailored around what's needed to keep that individual or the care receiver at home. So the services wrap around the care receiver, and some of the potential services could be chosen can be focused on supporting that family caregiver to keep that care receiver at home. So the waiver program, it actually created this new eligibility group for us. So as in this waiver, we could serve care receivers who we called sort of pre-Medicaid, or people who were at risk of spending down to Medicaid. We knew they were sort of close, but they wouldn't qualify necessarily for Medicaid itself. So these would be people at like 400% of the poverty level. So these services that were available would be caregiver assistance, like, respite care, housework, errands, chore services. It would include things like support groups, long-term, help with long-term care planning. It might be OT, PT, dementia-related education, falls prevention, or how to lift and transfer, sort of training caregivers on how to do what they need to do. Or it could include specialized medical equipment or supplies, like incontinence supplies, or an emergency response system. So when developing this program, we really worked with intention to make sure that the supports for dementia caregivers would also be there, like they were in our family caregiver support program. So it might be, training and consultation around dementia behaviors, or family caregiver counseling, or specific wellness programs that might help family caregivers. So at this point, we're now in the 7th year of this 1115 waiver. And I will just share with you on the next slide that what we know about this is that Washington State's caregivers are benefiting from having this expanded funding available, and the state's benefiting from the fact that CMS, through this waiver, is paying 100% of that program cost. So this waiver is a way to get federal funding to provide family caregiver support services to more individuals caring for loved ones who are at risk of Medicaid eligibility. So that really helps us to be rebalancing from those more expensive and costly Medicaid services to the more cost-effective supports for family caregivers. So I know that the print's a little small on this, but you can see on this slide that through our 1115 waiver, we spend around $800 a month on average for these to support the family caregivers. But if we were paying for the care receiver on the Medicaid side, the average Medicaid average expenditures would be, if they were in-home or community residential, would be about $3,500 a month. Or if they were in nursing home care, it'd be around $8,000 per month. So, you can see that there is definitely an economic reason why supporting family caregivers is a good idea. As I finish out this section, I hope my walk through this use of grants and data and evaluation has just spurred maybe some ideas and opportunities that others of you might use, or you might already have used some of this ideas, and you might have some great data that you've been able to pull upon to make your case. So I just want to take a little break and from talking and ask you all with this next question, if you put that, thanks, Elma. Do you have any specific data sources, or maybe even funding sources if you haven't, things you've been able to leverage to perhaps improve upon or expand family caregiver support program in your state? So let's just take a minute and see if any of you guys has ideas to share with us around what you've used.
Thinks about the response. This was amazing, Lynn. Thank you. Great work. This is great. Thank you for sharing all of this. And I just want to say, because of technical difficulties, I have been unable to drop in the chat many of the resources that Lynn and Marcy have prepared for you. Maybe we can get access to them later during the presentation, and we will start dropping them in. But otherwise, they will be links to for example, the waiver program that we can learn more. We will share those after the webinar.
Great.
Yeah, please share in the chat some of the things that you've done similar. How did you use data creatively to demonstrate, to really make the case for increased funding for caregiver support program in your jurisdiction? Maybe it's easier to say it. Maybe raise your hand if you would like, Lynn, or unmute yourself.
We have some pre and post test after caregiver education programs. Yeah, it's always good to know, are you really making a difference in those? So that's a great idea. Thank you, Alexis.
Hi, my name is Rashonda, and I just would like to share. I'm from Southern Mississippi Planning and Development District in Mississippi, Hattiesburg, Mississippi. We're an area agent on aging, and we were recently awarded the Alzheimer's disease program initiative grant from the Administration for Community Living, and that project that I'm currently heading off, initiating, and basically information from resources from the State Department of Health, the BOLD grant, the Alzheimer's Association help to, I would say, leverage out, us in making a case, in receiving funds for Mississippi. So we are a community-based agency, and this will be the first of its kind for Alzheimer's and caregivers for the state of Mississippi. So we're in process of that now and developing that program here in Mississippi.
Oh, thanks, Rashonda. Those grants are just wonderful opportunities, and they're a lot of work, but they're they give you the opportunity to build out your partnerships services, as well as get some good evaluation data. So good luck with that. Yeah,
thank you.
Great opportunities. All right, I don't know how many other of you have participated in those kind of Alzheimer grants or other opportunities like that to demonstrate services, but they really are one of the best ways, starting out small. If you're working to create partnerships, even starting out on a small project, really starts launching you into future projects and future partnerships. So anything you can do to, start that kind of work is just a great opportunity. Does anybody else want to share any thoughts they have? Okay, well, I'm not seeing that. So I just have a couple more slides before we transition to Marcy. So why don't we move on into that next slide, Elma? And I did, before handing this off to Marcy, I just want to mention a couple other policy approaches that have been helpful for dementia caregivers in our state. So you've probably noticed by now that Washington is fortunate in that we have a really supportive legislature towards long-term care and family caregivers. So here I just want to mention a couple pieces of legislation that were passed in Washington state that have a broader scope to support family caregivers, including those with dementia. So on the next slide, you'll see we have Paid Family and Medical Leave Act, which our legislature passed in 2017. So Washington is one of about 11 states that offers paid family medical leave to workers. And if you're not familiar with that, paid and family medical leave lets employees take time off work when it's needed the most to offer stability for their job so they can't lose their job and some peace of mind so they can focus on what really matters and, you know, they're helping their families. So the program provides in Washington state 12 weeks of paid leave per year to care for a family member with a serious health condition. So program participants can receive 90% of their weekly pay up to a maximum of $1,000 a week. So the program is funded by premiums paid by both employees and employers, and all W-2 workers, anyone who completes a W-2, and most employers pay a modest premium. And premiums started being taken out in January of 2019. So it's a relatively new program, but Washingtonians began to submit claims for paid family and medical leave in January of 2020, right as the COVID was starting to hit. So this is still relatively new, but I do know personally of several people who've been able to access this program and find it a great relief to know that they can attend to their family's needs without fearing for losing their jobs or adding that financial stressor of being away from work. So on the next slide, I just do want to mention Washington State Legislature enacted what's called the Long-Term Care Trust Act to address a problem that a lot of states are dealing with. The fact that we expect to see our population of older adults more than double by 2040. And this related concern about how are we possibly going to provide long-term care for all these people, the many, many people who are going to need it someday, because we know from a lot of research that the average cost of long-term care service and supports is almost twice as much as what the average American has in retirement savings. So with this in mind, our legislature passed the Long-Term Care Trust Program. And this is meant to assist individuals in accessing long-term care and delay the impoverishment that can occur with paying for long-term care. So the trust is being funded by a modest payroll premium paid by Washington workers with few exceptions. In the first year, each person who is eligible will receive a lifetime benefit of $36,500, regardless of their income or assets. So everybody, regardless of what they make, gets this same long-term care benefit when they need it. So again, you'll note this is very new. In fact, payroll deductions, we just started getting it taken out of our paycheck just this last July 1st, 2023. And the first eligible Washingtonians will be receiving long-term care benefits in 2026. So this program has now been renamed or branded as WA Cares. And like most of our long-term care programs, it will offer supports for family caregivers as they are helping an eligible care receiver who has memory loss or dementia. So you might want to keep your eye on this over time because it really is one of the first of its kind in the nation for a long-term care support program that's publicly funded. Okay, and then on the last slide, I just do want to share with you something that's directly related to dementia caregiving, and that is our Washington State Plan. Our Washington State Plan for Dementia was authorized in 2014 and published in 2016, and it was just recently updated. It has a whole goal devoted just to dementia caregivers. And from the start, our state plan has been really fueled by the energy and commitment and passion of public and private organizations, advocates, individuals, and multiple state agencies. So on the next slide, what you'll see is that the original Alzheimer's disease working group that developed the first plan transitioned itself into something called the Dementia Action Collaborative, or the DAC, to guide and implement the plan. And the DAC is spearheaded by our organization, Aging and Long-Term Support Administration, but operated cooperatively between 4 state agencies that you see on the screen. And since the plan was published in 2016, the Washington State Legislature has incrementally begun to fund recommendations in that plan, starting with the funding of dedicated staff in the 4 state agencies you see up on the screen, which includes the Department of Health, Healthcare Authority, Developmental Disabilities, and our organization. Next slide, please. So, I do want to share one of our first collaborative efforts, which we didn't have any funding for, but we just did because people thought it was a need. One of our comments from a caregiver during one of our meetings was when he stood up and said, when his wife was diagnosed with dementia, I just didn't know what to do, where to go for help. I needed a roadmap. Can you help me with that? And so our collaboration answered by developing this product called the Dementia Roadmap. And what's interesting is that this has turned out to be a cornerstone of our work, because while it's targeted to inform family caregivers, it seemed to strike a chord with professionals like doctors and case managers that really benefited from having this paper concrete tool that they could talk and look at when they were working with somebody to help families who were living with this dementia and try to work through those steps. So the document walks them through varied stages from the time when people are wondering and worried about memory loss and all the way through the progression of dementia, sharing what they can expect, what a family caregiver can do to help. And it offers specific action steps that people can take at each step along the way. And then on the next slide is another tool that we developed. And this was intended to address a problem that too many people living with dementia were getting to those late stages with no legal or advanced care planning paperwork in place. And we wanted to encourage and enable the completion of paperwork. So as you know, it's important for people to make plans about what they want at the end of life, about who's going to make decisions for them. And they need to do it while they have the cognition to do so. So making these plans is one way that we can relieve some worry for family caregivers about the road ahead. So with our collaborators, we developed the Dementia Legal Planning Toolkit you see up on the screen. And then knowing that families will sometimes need some professional guidance in completing those forms, we requested and received funds from the legislature to develop not only the sort of dissemination of this legal planning toolkit, but to fund an organization who in our state is called the Washington State Pro Bono Council. And they have a coordinator who provides training for attorneys on the topic of dementia, on the topic of completing these forms. And then they work to coordinate and connect people who need assistance with trained pro bono attorneys to assist them in completing these powers of attorney and healthcare directives. So then this is just my last slide, and I just want to, just show you sort of our summary of the progress we're making because of our state plan through the Dementia Action Collaborative. So this slide shows on the bottom.
I think Lynn's screen froze. So given time, do you just want me to sort of speak to it, Elma, and then we can move forward?
Yes,
So,
absolutely. And if Lynn comes back, she can help.
Okay.
Yeah, go ahead.
So the legislative, we're just talking, this slide is to just talk about, how supportive our legislature was, and that these are on the sort of the greenish color are the DAC funded initiatives that we've been able to participate in. And then also on the right hand side of your screen are the collaborative projects. So we've done a lot, and you'll be learning more about some of these in my part of the presentation. So I think we should go to the next slide.
Oh, okay, I'm back.
Oh, Lynn, I just reviewed this slide for you.
Excellent, great work.
Okay.
Thanks, Marcy.
Yes,
Carry on.
sure. All right. So anyway, thank you so much, Lynn, for your great presentation, and good morning and good afternoon to folks, depending on where you are and the calling in from. And I just want to really thank you all for spending the time with us today. And also I want to thank the Bold Public Health Center on Excellence on Dementia Caregiving, especially Alma and Maya, for your support with this presentation. And again, I'm Marcy Getz, and I'm the Director of Healthy Aging at the Washington State Department of Health. So, something happened to the slide, but anyway, it's supposed to say presentation outline, the next slide, but maybe in the transitioning of the slide. So if you see things like that, know that that's not intentional. Sending such big slides, sometimes things can happen. So today what I want to really talk to you about is the strategies that I and my colleagues in Washington State have used to build public health champions in state, local, and tribal public health. And I'm just going to give you examples of initiatives demonstrating, the many roles public health can have. When I've talked to some colleagues in different states, some have had tremendous response from public health, and others have had a struggle finding champions in public health that see their roles in this work. And then at the end, I'm just going to share with you some of our plans for the BOLD grant. Next slide, please. So I thought it would be fun and also maybe informative to you to share my experience coming to this work. So in my public health training, I didn't study anything on aging, Alzheimer's, or dementia. I focused on health equity work, and that definitely comes into play here. But so in end of 2015, early 2016, when they were still developing the state plan, one of my colleagues left her job and went to a different position and said, could you fill in for me? And I'm thinking, sure, this sounds really interesting, but gosh, I hope I have something to offer, because I don't really see public health's work in this work. And so I went to the meeting, and then when the state plan was finished, they developed the Dementia Action Collaborative, which, like Lynn said, we call the DAC. And I'm in their public awareness and community readiness subcommittee, which seemed to fit with some of my public health background. But I remember driving those days when we were all driving to meetings. And if you've ever been on the I-5 corridor near Seattle, you spend a lot of time in your car when you're going to meetings up there. And I remember saying to Lynn, I'm not really sure I see our role, Lynn. And Lynn's like, oh, well, let me tell you your role here, And she introduced me to then, I think it was in 2017, the Lancet Commission report. And now I have on the screen here on the right-hand side, a picture from their updated report in 2020 that talks about modifiable risk factors. And everything is connected to public health, and it's also connected through the life course, which is how public health works. I really encourage you to take a look at that Lancet article and even this this infographic. So what I guess I just want to let you know is that I don't think it's always obvious to those of us in public health what our role is in this work unless we have someone to help us see that role. So next slide, please. So I'm just putting this up there, and this doesn't include all the wonderful legislative funding we got in our state, but I just am putting this up here because I think it is really important to harness opportunities. So again, I came to the Dementia Action Collaborative because I was asked by a colleague, and now it's most of my work, and I love it. And so in 2017, the Association of State and Territorial Health Officials, or ASTO, and the National Alzheimer's Association had a small grant they put out. And our public health, we don't often apply for really small grants because it still takes a lot of time and effort from staff. But our partners at the Dementia Action Collaborative said, please apply. So we did, and we were accepted in it. And it was a great opportunity. It sent me to a training where I learned more about the public health role, more about dementia, more about the needs of caregivers. And it was just a great experience. It partnered you with your local chapter of the Alzheimer's Association, and you worked the Healthy Brain Initiative Roadmap that's just come out, the new one. In the old one, they asked you to put forth at least 2 of the strategies. So it was a great introduction to all of that. And then we participated in a learning community, again, offered by ASTO and the National Alzheimer's Association. And then in 2018, a colleague and I went to a Healthy Aging Summit in Washington, DC, and there was an HHS Region 10 Healthy Aging Work Group, and we became a part of that. So with other states in our region. And so from all those things, we started to work together, to collaborate, to learn. And then in 2020, we were so fortunate to work with Trust for America's Health on building age-friendly public health systems. So I will be telling you more about it, but I just share this with you to say, even if something seems like a small opportunity, you have no idea where it might take you and the seeds that will get planted. Next slide. So this is, if you're not familiar, I definitely check out their website as well, Trust for America's Health, Age-Friendly Public Health Systems. And the funding that we in Mississippi got, my colleague, Dr. Keena White's done amazing work, was to develop age-friendly public health systems within our state. And so if you see on the right-hand side of your screen, the TIFA has developed the 6 C's with advancing health equity in the center where it should be, and around healthy aging. And these C's are things people do all the time in public health. I'm not going to read them to you, but just one example is connecting and convening, bringing people together, analyzing data. And so what we did is we asked folks in our state if they would work with us, both tribal public health as well as local public health. And as you can see, we had a participant from the Northwest Washington Indian Health Board, amazing woman, and they represent 6 Washington state tribes. We had 4 local health jurisdictions spread throughout our state, and one local health jurisdiction, because of staff turnover, had to stop participating, but their community department, their county department of community and health services stayed and worked with us. And we had 4 area agencies on aging that participated. And one of the things that's so important in all this work is the partnerships. And one of the goals of this work was to get area agencies on aging and local or public or tribal public health to work together. And it was a great synergy of knowledge between both groups and supporting each other. And I'll just give you one quick example. Is one of the area agencies doing just amazing work, they didn't have an epidemiologist. So the public health group gave some of their time to them so that they could help look at the data, which really helps both. It helps the whole county. So just gonna get a sip of water. So anyway, it was a great synergy. And again, people had the opportunity to learn. We had called it our Age-Friendly Public Health Systems Learning and Action Network. And I think it's just so important to bring this information together and learn from our colleagues in aging that have done this great work and see what our role is in public health. Next slide, please. And I'm just going to bring up a few examples and learnings from Washington State. And Lynn already talked to you about the BRFIS and things we've learned, but Washington State has an amazing BRFIS team, and I've learned so much about some of the challenges and how they've tried to overcome them, because we don't always get the best response rate in our state. People don't necessarily want to participate in surveys. And so we went to them and said, we really want the optional caregiver decline and the optional cognitive decline and caregiver modules run. We'd like them run every 3 years. And what they were experiencing was challenges, because once they got all the mandatory questions run, they were almost at the time limit for what an effective survey is, a phone survey. But over time and working with them and their support, they helped us realize that we would get those run if we had measures in our state plan to require this data. So that is in our state plan now, our Alzheimer's plan to address, our state plan to address Alzheimer's and other dementias. The other thing is that to analyze the data with other chronic diseases that are run the same year. And we're learning a lot from that. And just also to make the case on the data relevance. So you and your state may have no problems getting these in, but we've had some challenges, and working together, we've been figuring out ways so that this will happen. Next slide, please. So I'm hoping to learn from all of you. So how has your state used the data from BRFIS, cognitive decline, and/or caregiver modules? Who is the data shared with? And how do you share the data, or in what format? So like, for example, we go back and share it with our Dementia Action Collaborative colleagues. we're trying to make sure we share it with policymakers. But who are you sharing your data with, and how do you share it? Because Lynn and I are always talking that we could do a better job with this. So I'll stop for a minute and see if anyone has any responses in the Q&A or in the chat.
And Marcy, just
Yeah.
orientation, we have 27 minutes left to the end. You're doing good.
Okay.
Just
Okay.
giving thumbs up.
Mhm.
Hi there.
Hi.
My name's Heather O'Connor. I'm the program director for New York State Department of Health Center for Excellence for Alzheimer's Disease. I worked with our ACO to get data on the incidence of dementia regionally for the 6 counties I'm responsible for in this program. And I've been sharing it at the provider level and with administrators, because I think that's a starting point for the conversation. And it also, I think, helps people understand their role in the early diagnosis process.
Thank you. Thanks, Heather. Can I ask you, when you do share it, do you share it via email, or do you share it? How do you make sure they see it?
It's been visually with presentations.
Okay.
But it's a good point, because having sustained data for people to be able to reference back to is important.
Great. Thank you, Heather.
You're welcome.
Thanks. And I see some others' responses, and people should definitely take a look at the Q&A in the chat. And I think I better go on because of time. But thank you for sharing those things. And I look forward to seeing what else people write. So I'm going to go to the next slide. So the next slides that I'm going to share with you, and I'm probably going to go a little more quickly, are also opportunities where the Dementia Action Collaborative have gone to the state legislature, and we've gotten funding for things. And they have said, well, they came to Department of Health and said, wow, you know, we really could use you to help us with these campaigns. So this is how we've gotten our funding for this. And we're going to carry some of this forward now with the BOLD grant funding. So our state legislature understood from probably the education that my colleague Lynn and her agency have provided, is that oftentimes research has shown that oftentimes people don't bring up concerns about memory with their provider, and providers aren't comfortable bringing it up with their patients. And so we got a small amount of money to do a campaign, a digital campaign, about the value and importance of an early diagnosis and planning. Can you go to the next page, Elma? Or slide, I mean. So Elma or Lynn will put this link in for you, but what we did is we worked with 2 different organizations in our state. Oh, let me backtrack for a minute. We have a group of people that I call our campaign work group, and they're people from the DAC, they're people from the community, a community-based public health organization that is in Seattle. So a lot of different people are on this work group, and then we have hired some partners, agencies, to do this work. And what we have done is they've done research in the literature, they've done key insight interviews with professionals with both lived experiences from those communities that they're working with, and professionals in the field, and then they've done focus groups. And we decided to begin with our work with the Black and African American communities in our state because of the higher prevalence rate. And also the next group that we had chose to work with was Hispanic and Latinx. And so I just want to show you, you can go to the next page. So we have it in English and Spanish. And if you can go to the next page, next slide, I keep saying the page. So this is just an example up here of one of our brochures. It's in English and Spanish. And then we have things on so the website, when you go to it, the first page is really all for the consumer, or the person looking for information for themselves or their family. The next page is resources, social media, brochures, letters for public health and other organizations. And the idea is that we know that it isn't a lot of funding, and so we know just doing a digital campaign or putting something on the web is not enough. So we needed to get trusted messengers within those communities, such as churches, faith and community-based organizations. And so with some funding from Aging and Long-Term Support Services, where Lynn works, we've done a few pilots and they've gone very well. And one of the things I feel really good about with the pilots is we're providing people the information and some training, but they determine how they're going to reach their community. Is it going to be a health fair? Is it going to be a webinar? Is it going to be an in-person presentation to try to share these messages? And when we do the trainings for people, we always talk about the fact that the difference in prevalence rates, we're trying to understand what, causes those different things, but we know that part of it is rooted in the historic and structural systematic racism that people experience. So we're very upfront and transparent about that. And it's really important to us that people don't feel like we're blaming them for the prevalence rates. And that but it's important to let people know what's happening and to try to go get support and assistance earlier on. Next slide. So the next thing I'm going to tell you about, but I'm just going to say that with our funding for the BOLD grant, we're going to continue that work, as well as continue to work with organizations to talk about what are the modifiable risk factors that they might want to discuss with those who are in their community. Well, the other thing I wanted to highlight for you today is that after we were at the Healthy Aging Summit in 2018, we realized that we didn't know at our own Department of Health that has about 2,000 employees throughout the state of Washington, what were we doing around aging work? And we didn't really know. So what we did is we used the Healthy Brain Initiative roadmaps, and we used an older version because we created the Department of Health Healthy Aging Work Group, and it was for 1 year. And what we did is we made the case to agency leadership that this is a public health issue, and could you please send folks to this work group? And it was so exciting because so many people were really invested in this topic, and many had very little experience around aging and these topics like I did when I first came. So can we go to the next slide? So what I want to tell you is we did an assessment. That was our work group's mission, is to do education and information to then inform an assessment. And we use, on the left, you see the Healthy Brain Initiative roadmap. And they're the 4 domains of public health action, and they're also around the essential services of public health. So you see them: educate and engage and educate, build a diverse workforce, measure and evaluate, strengthen partnerships and policies. And then on the right, you see we use the life course perspective, because that is public health. It's looking at where along in your life you can make opportunities for people to have better health. And also, it really talks about social determinants of health. So on that Lancet infographic I showed you a while back, your education impacts your brain health. And so if you're living in a disadvantaged neighborhood, you may not have the same quality education as someone else, or you live in a neighborhood that has a high pollution rate. So there's just different things that impact people's lives and their trajectory all throughout the course. And so we help the group see that really there's so much and so many places to intervene on brain health. Next slide, please. So with our assessment, we ask people, what are they currently doing to focus on healthy aging? And what are they doing that might already be listed as in the Healthy Brain Initiative roadmap? In the old roadmap, there were 25 activities for state and local public health. And then we did another category, which is, how could you take what you're doing and look at the roadmap and what you've learned? And what happened was people across the group came up with 89 new opportunities. to implement healthy brain initiative work. And I'll tell you that some of them were things that they could just include right away in messaging at no cost, like around smoking cessation, stroke, diabetes, but there were others that might take some funding. And one of my colleagues who was helped me lead this work, she asked at the first meeting, is anyone missing? And someone said, yeah, someone from employee health. And that person has become a huge champion. So I really encourage you, if you bring a group together, and you might all already know this, but I would ask, is anyone missing? Next slide. So I'm just going to go through these kind of quickly, but just to let you know some examples that came up under those domains. And so under educate and empower, for an example, our employee person said, we really need to figure out, we have a lot of people here who are employees and who are caregivers, and they might be caregiving for children and their parents. And so coming up with support for them. I'm going to go to the next slide. And under developing policies and mobilizing partnerships, what was so fascinating to me is, I mean, we had people from all over our agency, and some were facility licensure folks. And they said, wow, we need to do a lot more with getting stakeholders that are caregivers of people with dementia or people living with dementia to inform our work. Next slide. And for the Assure a Competent Workforce, just a really easy one would be when you're training folks about blood pressure to include messages about the benefits to good brain health for those that you're teaching about taking blood pressure, who then can pass it on to their patients. Next slide. And monitor and evaluate, I mean, that is so public health. And so I'm not going to really spend much time on this other than, you know, we had someone from oral health, and she really taught us a lot and about some of the connections between long-term gum disease and dementia. Next slide. And this I wanted to just share with you is that we were asked after presenting on this, how'd you do it? And so we had an amazing MPH MSW intern and an amazing designer at Department of Health who helped us come up with this toolkit. And I know that the link will be in the chat, and that it has everything you'd need to do your own assessment, and you can take what you need and leave the rest. And if you ever have questions about it, don't hesitate to ask. Next slide. So with our BOLD grant, very quickly, I'm just going to tell you that we are going to, you know, obviously have health equity in the center. I mean, that to me is a huge public health message. Equity is a huge issue around this, and prevalence. And we need to, that should be the center. And again, we're going to work, as I told you, about continuing to educate people in the communities, and we're going to give funding to those organizations to cover their staff time. We're going to also educate providers in our state. We're so lucky to have the Project Echo Dementia, and also Cognition and Primary Care. And we're going to take that to our federally qualified health centers, so people who have less money and less insurance have the opportunity to hopefully see someone who has training in this topic. And then increasing community and health linkages and use of data. Next slide. So Washington State in 2022 decided that as our strategic plan that we would have a transformational plan. It's really exciting, and I just wanted to point this out. And the work we're doing is strongly rooted in this. It's community-centered, it's equity-driven, and it's collaborative engagement. Next slide. So this is at a point, I think, now where what we'll need to do, Alma, is decide whether or not to move forward with this question or just general questions. Given our time, we've got about 13 minutes left. So I will let you decide because you're seeing the questions.
How about we try to integrate in the Q&A later? I will let you finish maybe the content, and then maybe we can come back to it later. We have
okay, I think we're done now. I think this is our last slide.
Oh,
Oh,
really?
besides our contact information, yeah.
Okay, well, how about any answers? Anybody wanting to share what their
Examples
answers?
of public health efforts to engage in and address the health needs of family caregivers.
Any initiatives? We're especially interested in the work by public health departments here attending bold or non-bold, but also their collaborators. And I see Sam Smith. You're raising your hand. Please unmute yourself. Go ahead.
Hi, everybody. My name is Sam Smith with the Alzheimer's Association. Thank you all for this great presentation. I'm really inspired by what we saw and hope to bring a lot of this here in Minnesota. Wanted to share some exciting work we've done in the last legislative session to fund culturally relevant outreach around Alzheimer's and other forms of dementia, including healthy aging strategies and the importance of an early diagnosis. We think that'll be really important. And on the caregiver side, have really been laser focused on expanding access to respite care with some modest success. But excited to see what other folks are up to.
Thanks, Sam. That's exciting to hear about.
Well, if there's anybody else who would like to speak up, please raise your hand. Otherwise, continue to share in the chat with comments, links, and resources. We are going to move to the Q&A. I just want to say it's been a great, thank you so much, Lynn and Marcy. It's been a great session. These sessions just get better with each installment. I learn something new every time. And we have a few questions in. This one is from Sarah Saint Hamilton, and it is for Lynn about the T-Care tool. So I'm going to combine that with another question that I had related to T-Care for you, Lynn. So Sarah asked, is the screening and assessment a standardized instrument or one that you all have developed? Is it available anywhere?
Yeah, that's a great question. And when we first developed it, it was not put into the model that it is now. So Washington State, we have a lot of experience with developing sort of algorithm-based type things. So we actually internally developed our own T-Care model. Now, if you were to go to T-Care, they have a tool you buy into and you pay, by how many people use it per 6 months or per year. So it is a different way to access it now, because we were the first state to do it. We had to develop it on our own, and then their own people developed their own little system to do it. So if you wanted to enter into T-Care now, you would need to go to, and I'm sorry, I'm really blanking on who you'd go to now, but I'd be happy to get that to you if you want to send me an email, and I can talk to our program manager for T-Care and get you to the exact right place where you get to that T-Care model, because they have developed their own system, which works to create sort of that consistent use across users. So they provide a training, they provide the tools and all the information in that sort of business model now. I hope that answers your question, and I'm very happy to get you to our program manager after this. If you could help link us up, Elma, that would be great.
Yeah, absolutely. The other question that came up as I was listening you talk about T-Care, just for my own education. So
Sure.
Who all gets to use T-Care? Who all gets to administer it, and what touch points? For example, do also health systems providers or somebody in the clinical staff get to do it, or is it done mainly in the community setting? And then how is the follow-up on that and communication to the healthcare provider done about the results? Is there any?
That is another great question. And it is because we have put this within our family caregiver support program itself. So the people who can use it are the people who get trained, and we pay for a license for our family caregiver specialists throughout the state. So as I mentioned, our programs are run by our area agencies on aging. So they would have people in their family caregiver support programs, and they do sometimes have network partners, so aging network partners, such as perhaps the Alzheimer's Association in the Seattle-King County area has a contract and a license to be able to be the provider of that tool. But we have not, this has not gone in our state. We did not develop it to go into healthcare systems. It could very easily be used. And there are other states who have had people using TCare in different types of settings like that. So whoever is that licensed person who gets trained is the person who follows up, Elma. So, you know, you have that one specialist that you work with who does the assessment and then who creates the care plan. It's a negotiated care plan between our people will say, this is what we think would work for you. Which ones are you willing to accept at this point in time? What do you want to do? They develop the care plan and then they move forward. And then 6 months later, that same specialist, assuming they're still in their role, comes back and they follow it again as a cycle. So it's always that same person. That's how it worked in our system. Now, other people, as I say, in different health settings might have adopted TCare to use in a different way. But the whole idea is to create that consultative model with a caregiver, to have one person that you are connecting with that knows your needs and can connect you and get you set up with services. Does that answer your question?
Yeah. I was just curious who all gets used and whether it touches in dementia care within the healthcare setting. If there's any connection there.
It would be great if it were used in healthcare settings, I think. But we have not been, because we work primarily with our system to get it. And that's big of a challenge enough.
Thank you. The next question for you, Lynn, again, from Julie, I guess. Curious about the delivery method for the education supports to family caregivers. Are they in person, virtual, online? And the content source for such training. Perhaps maybe you can share like a link. Do you have a website available where this can be?
Yeah, and it's there. That's another great question. Typically, when we first started this out, like even before the pandemic, I mean, a lot of our AAAs might contract for this kind of service, say from the Alzheimer's Association, or they might contract for another provider to do different types of sort of individual education. During the pandemic, we did as a state buy into an organization you guys might have heard called TruAlta, and they are a web-based online training program, and they offer a lot of different types of caregiving online, but a lot of it is focused on dementia, because I think a lot of the family caregiver world focuses on people who are caring for a person with that. We also have an internal website that we use to educate our adult family home providers, people who are not in a, this is more complex than you need to know, a bargain system, but it would include family caregivers. It's called CareLearn. So we have 2 different online module ways that people could get online training, but we also link them up regularly with community partners who can provide that education. Some under contract, some are just partners like the Alzheimer's Association who do that. So I hope that answers your question. And again, I don't have that TruAlta link up because it gets branded differently by each state. It's called something different when the state buys it, but I could send you a link to TruAlta if you can give this person me their email, and I could send that to them.
Yeah, just take note. There's another question about funding and this really innovative ways that Washington has for really for funding the work, family caregivers and sustaining it. This is a question from Kim. How does this state funding work with people who are non-kin, non-family, not familial caregivers? So maybe it might be a friend.
Yeah.
Do they receive the same benefits and supports? Are they eligible for the services? How does that happen?
Yeah, we consider family anybody who the care receiver considers to be their family. So, it's pretty inclusive. If you have a neighbor who has always been the one checking on you, we can support that neighbor in doing that. So yes, it is pretty broad in that sense.
This is a question from Heather O'Connor, a specific one about the legal planning initiative. When the legal planning initiative was trained, you mentioned dementia was training was provided to attorneys, which I assume might be attorneys practicing in the community. Did you train judges as well?
No, we did not, but somebody recently brought that up. That's very interesting that you asked that, and thank you for bringing that up. We have been hearing about that more and more, and we did not specifically do that, but I think it would be a great step, quite honestly, and it might be one that we'll get to because, as I said, somebody just recently was bringing that up, and you know, the training that we have, this pro bono council, and the reason we've been able to do this effectively, quite honestly, and this is really one of our strategies, is we look to see who is sort of doing something that is really close to what we want, but then can build on this sort of dementia capability. So what was interesting is this pro bono council, they are like a group that they work with these pro bono attorneys. We have 17 pro bono volunteer lawyer programs across our state. They're already doing pro bono work, right? So they are in contact with these attorneys. They go out and they do, like, you know, wills clinics and fairs, and they try to get people, you know, very interested in the type of you know, stuff we're doing, but they weren't really involved in like dementia at all. So we asked this group, would they be interested in adding this dementia world of powers of attorney and advanced care planning onto their sort of existing bank of work? And, you know, it was a really nice fit for them because they're already out there doing work with trying to get people to do their legal documents like wills and trusts and stuff like that. So adding this layer of dementia capable knowledge to this volunteer pool who can go out and do these clinics was a really good fit. And that's, I think it's just a good example of using the partners that you have, like who are the assets you have in your community where you can build that dementia capability, because then you don't have to build a whole new system. They already had these links with these volunteer lawyers, and we just came in and started working with them around this issue of dementia and the importance of getting people to do that before dementia, ideally, but if not, shortly after a diagnosis. So it's been a really nice fit, and I think a good example of how you can work with partners to build out your work a little bit.
Thank you, Lynn. And then, oh, I just wish we had more time. We have 1 minute left, and I think I just found a question from Monica in the chat. And this one actually might be from Marcy. Marcy, and again, Lynn, you can add to as well. What, if any, data points would you recommend capturing that you may have initially overlooked in order to best align with supporting local policy? To support maybe policy initiatives, communication with policymakers, I assume.
I think Lynn's organization has done a beautiful job of over the years, as you saw her in her presentation, really capture sort of the return on investment and the importance of things. So like, but the other thing that I don't have a specific answer for public health, other than we're hoping to at some point do a data dashboard, because I think it's really, really important for us to start looking at, and other states are starting to do this as well, which is great, is making sure that people have access and understand what are the issues that older adults are facing and what are some of the things that we need to put in place, and where are the social determinants of health at play. Lynn, do you have anything else you'd add?
Well, you know, the thing that I would add is it's not so much from our point of view. I wish healthcare would do a better job of identifying memory loss and cognitive impairment, even if there isn't a diagnosis yet, because there is all this hesitancy on the part of providers, you know, to do the wait and see, and they don't want to give a diagnosis. But I think we're getting a lot of people who have cognitive impairment and they land in an emergency hospital, and then the people don't know this person has cognitive impairment or dementia. It's just not diagnosed, because we know people don't want to go and get a diagnosis, or they're not getting that diagnosis. I wish healthcare could come up with a way to identify cognitive impairment and or, you know, suspected dementia in their charts in healthcare. And I also wish, I will just add one more thing, I wish healthcare could do more about identifying family caregivers in their charts, people who are actually taking responsible for people who provide care, because, you know, families are the ones that they're going to go home to, the ones that need to provide the support. So I would say I would recommend that, but on the healthcare side primarily, if anybody can move that needle a little bit, would be really helpful. Thanks for asking that question. That made me really try to think about what was the most important. So thank you for asking that.
Definitely a clear opportunity for public health there to leverage those partnerships and really model You mentioned Marcy earlier, FQHCs, and maybe how they usually tend to be very innovative, even with their limited resources, in trying out new things and what works, things that work that don't work. And sometimes those little pilots and partnerships really can serve as great examples of how this can be done at the health system level. So we are over time, actually 2 minutes. This has been an amazing session. Thank you so much. I'm thrilled to see that over half of our attendees here are still listening. Just shows how much interest and really the value of these sessions. Thank you for being here with us today, everybody in the audience, and special thank you to Marcy and Lynn, to both of you for sharing your work. We will share the recording, the slides, and the resources that we were not be able to share in the chats with you in the follow-up email. My colleague Maya usually does that very thorough follow-up to all. Thank you, Maya. Yeah, thank you all again.
Sorry to interrupt you, Elma. They just wondered if you could show the last slide with the email addresses.
Yes,
for
thank
just
you.
a second.
Let me see.
Thanks,
Yes,
Elma. Sorry. I just saw that in the chat.
And then just a gentle reminder, we really appreciate your feedback when you close. Do accept that invite if you don't mind, and just to answer a brief survey. That's what we use to improve our programming and choose topics for our webinars like these. Don't hesitate to reach out to Marcy and Lynn for any more, with any questions. I know I will.
Well, thanks again.
Thank you guys, and thanks for all your good questions.
Thank you.